This is our Physical Findings Friday, March, the baby edition. Hence, we're having Dr. Gibson. We also kind of did that last question in honor of Dr. Cooper because he's been such an awesome teacher over on the baby side. All right. So, reminder, these first two cases are radiology films. So if you're able to, then just take a moment to dim the lights or turn them off so you can learn the most and see the pictures. All right. So this is kind of a general approach to the neonatal X-ray. This is honestly kind of taken from Radiopedia, which I think had a really nice approach. And I think that they had some really good tips as well as far as kind of test taking strategies, especially when it comes to this gestation and like age stuff. So between these two pictures, which are the same baby, I believe, and then this bottom picture, you can notice a big difference in the subcutaneous fat. That's super, super helpful as far as, you know, kind of deciding, well, is this, you know, when I'm thinking about the differential, do I need to be thinking about term baby things like TTN, or do I need to be thinking about preterm baby things like RDS? The red arrow is pointing to a big hole nematocele that this baby also happened to have. So this baby here is preterm and they have that nematocele, and then this is a term baby. Again, you can see a huge difference in the amount of subcutaneous fat. This is a little, the other thing that they mentioned is a little bit outside of my comfort zone and a little bit out of what I'm fully able to see. So if any of y'all really have experience with this or have other things that you noticed on these images, please speak up. There's kind of a difference in humeral head ossification. I think it was like, you know, at least half of babies by gestational age 37 weeks or so will have at least like some humeral head ossification. But it seemed to not be a super consistent thing. And then you can also see some like bone formation at the coracoid process as well. But again, that's kind of beyond, I think, at least personally, what I end up paying a ton of attention to. I don't know if any of y'all have any, you know, if y'all notice anything on these x-rays that you could point out that kind of help out. And then finally, some films, not all films from what I could tell, might have that visible umbilical clamp, which tells you that the baby is less than 1 to 2 weeks old, meaning, you know, the umbilical cord has not, or yeah, it's still attached. And then briefly about lines and tubes. For the ET tube, please not in the right main stem. I think that by now a lot of us have done PICU and NICU, and you know, so we've kind of gotten the gist of things as far as where we want the ET tube tip to be, meaning not in the right main stem, ideally not like literally at the carina, because that's kind of mean. The patient will cough a lot, and then you know, certainly deep enough as well. I've heard some people kind of roughly say at least below the collarbones, but it really depends on kind of the angle that the film's being shot at for sure. So ET tube, and then NG and OG ideally need to be in the stomach, not just like kind of at the GE junction. And then UAC versus UVC, how to tell the difference. So UAC is going to be the one that comes in at the umbilicus and then goes down, and then it goes up, whereas UVC is just going to go in at the umbilicus and go on up. Sometimes it'll get stuck kind of in like the hepatic vasculature is a common place for it to get stuck at. All right, so when we're talking about any sort of respiratory distress and neonatal chest x-rays, we have, and what really Radiopedia had basically the big three. So we're going to talk about those big three things. The first one is RDS. So as we know, this is kind of more of a preterm thing, but there are other risk factors like IDM, or infant of a diabetic mother. The real big problem here is we don't have surfactant going. We haven't really made it yet, and so the lung compliance is poor. This is going to be that ground glass appearance. We have a picture here kind of below, just to show another example of what ground glass might look like versus consolidation like we would see with a pneumonia. And then you can also, they sometimes call it like reticulogranular, which means more or less the same thing as far as I was able to find online. They'll typically have low lung volumes. Again, the compliance is poor, so those lungs are not going to expand well. That being said, this image here, the lungs are not terrible. I think I counted like 8 or 9 ribs when I counted it last night. The reason for that, though, is that this baby is intubated. So don't let that fool you and make you kind of decide one way or the other. Babies who are intubated and on a ventilator certainly can have normal looking lung volumes. Babies who are not intubated, it would kind of exclude the diagnosis actually if they were normally inflated or especially hyperinflated. You would say there's no way that this baby has RDS, assuming that they're not intubated at that time. You can sometimes see air bronchograms as well. On this baby, I don't really appreciate a lot, maybe a little bit in that right lung, and maybe a teeny bit kind of on the left too, but it's not stark on this picture for me at least. And then again, those risk factors are going to be IDM and then also prematurity. All right, next one, TTN. So this is a lot more common in full-term babies. Obviously, this can happen in younger babies, but it's not as common for sure. This is due to poor fluid clearance, as we all know. The risk factor for this is going to be C-section, and then also actually IDM is a risk factor for TTN as well. What's nice about this is that it should resolve by about 72 hours of age. So you're kind of just buying time and giving them supportive therapies while all this is going on. And that's it. What you'll see is interstitial edema, especially perihilar. And honestly, I have to I haven't thought about the hilum of the lung since, since like first year of med school. So to remind everyone, hilum of the lung is kind of that first area of the lung, right when the main stem bronchi kind of start off. And then we will have increased lung volumes. And so, as you can see, this baby does have increased lung volumes. All right. And then this is just showing that fluid in the fissure. I feel like that's kind of a nice dead giveaway for this a lot of times if you can see it and if you're confident that you're seeing it. So where I have the yellow line right now on the image is where there is a line where you see fluid in the fissure. So I'm gonna have it go away. Hopefully y'all can kind of see that line there. I'm gonna have it come back, I think. Yep. And then it's gonna go back away. All right, hopefully y'all can kind of appreciate that. Last of the big three, meconium aspiration syndrome. And I think that this is, from looking at the results of everything from y'all's responses, this was the one that kind of tripped some people up. So again, this is going to be full or even post-term babies.
Hey, Jessica, hang on one second.
Yeah.
So only does anyone else besides the elective people not seeing the slide that we're on right now? Their presentation seems to be stuck on that first slide, but is everyone else is moving along?
We can see it on wards.
Okay. So
yeah, Nick, you can see it.
You can see the meconium aspiration symptom slide.
The one's up there.
Cool. Okay.
Awesome. Sounds like maybe elective is not having good Wi-Fi, or I don't know. The third one is meconium aspiration syndrome. And again, this is kind of what tripped people up. Some people put this when it was actually something else. So we'll talk about this one as well. Again, full or even post-term babies, and the pathophysiology here, really it starts out with air trapping by the meconium. Obviously, full-term and post-term babies that are making meconium and possibly even already passing meconium are more likely to aspirate meconium. Basically, that air trapping leads to atelectasis, and then that leads to VQ mismatch, and that can even cause some pulmonary hypertension. Because it, won't necessarily go down all of the airways or, only certain airways. It certainly can be kind of a patchy appearance, but you'll have kind of more like coarse infiltrates. Again, because of the air trapping, just like in really like asthma or something, you'll have increased lung volumes. Complications of this, because there's a bit more air trapping involved and it's not like it just resolves within 72 hours like TTN, are going to be things like pneumothorax or pneumomediastinum. Risk factors, again, the big thing is post-term. I didn't actually see GDM as, or like infants of a diabetic mother or gestational diabetes or anything like that as a risk factor necessarily, just at least on up to date. That being said, I feel like maybe have seen that elsewhere. But post-term and term babies are going to be more likely to have this for sure. So kind of comparing these side by side. Again, RDS is going to be preterm babies. We don't see RDS much in the term babies unless there's like some IDM, especially if mom was really poorly controlled or anything like that during the pregnancy. A term baby without any risk factors, especially on a test, it really wouldn't be the answer. Again, you're going to have the ground glass appearance or reticulogranular, and you'll have decreased lung volumes before the baby is ventilated. Again, once they're ventilated, you can see normal or even hyperexpanded lung volumes. The treatment, of course, is give surfactant. Comparing that with TTN, it's going to be full-term babies, possibly IDM. Really, partially, if you think about it, for the IDM with TTN, IDM babies tend to be big babies, and sometimes they don't fit coming out. So that, that's kind of how I've always thought of it in a way, is it just kind of makes it so it's more likely that the mom would have a C-section. And then you'll have interstitial edema, and that'll give you kind of more of like a fine reticular pattern as far as how the lung x-ray looks. You'll see that fluid in the fissure, and then you'll also have increased lung volumes, but luckily it should resolve by 72 hours, and honestly, in most cases by more like 24 to 36 hours. Finally, for our meconium aspiration syndrome, it's going to be full or post-term babies that are old enough to actually have meconium and be passing it, and they'll have coarse infiltrates. I think on this image, especially kind of comparing it back to the other ones, you can really, really appreciate how coarse it is. They'll again have increased lung volumes because of that air trapping. And then you really want to be on the lookout, for anything where you're, ventilating, of course, you really want to be on the lookout for pneumothorax, but especially for these kids, just because of all that air trapping. All right, so if it's not the big three, Radiopedia, like I said, is kind of where I got a lot of the information for that section of this talk. They kind of go into different possibilities. And so, if they're ventilated, think about pneumothorax or PIE. Cystic looking can be things like CPAM and congenital diaphragmatic hernia, which I think we've all, seen films of and we're comfortable with. Consolidation is going to be things like pneumonia or pulmonary sequestration, where the blood supply is connected, but the lung tissue does not connect. And then also things like esophageal atresia are things to consider. That, again, is a really good page. They have a lot of good images, and I think it's a good resource for learning a little bit more about really radiology in general, but especially for this topic, I felt like it was super helpful. All right, so this was the first case. This was a 1-hour male, and the respiratory rate is 72. So let's see what we put. So first off, kind of color coded these for a couple of findings that we'll talk about. I tried to highlight the things that were kind of more commonly mentioned and correct. So a couple of y'all put fluid in the fissure, which I agree with. There's kind of two possible lines that I feel like I could argue there's fluid in the fissure, but I highlighted one of them. And so then also perihilar is, again, the location that we expect to see more of the TTN stuff. That's kind of where we're starting to get the fluid to come out, is how I think of it. And so perihilar, again, that's the area of the lung that we're looking at. And that's absolutely in this image where we see a lot more of the markings. And then a couple of people also said hyperinflation, which I didn't do an arrow for, I guess, but hyperinflation is also perfect because this image is TTN, and this baby has hyperinflated lungs. If you count down the ribs, I think, again, it was like 9 or so. There's a couple things that were a little bit off that we'll touch on real quick. There's tracheal deviation, one person said. For me, I feel like it's so hard to even like see the trachea in this picture. And admittedly, it's not a great picture. And then I think that, let's see, somebody said cardiomegaly. Again, cardiomegaly is going to be typically defined as the heart being, you know, at least a little bit over, I think, half of the diameter of the chest. I feel like the heart borders are just so hard to see in this that it would be really hard to confidently say cardiomegaly. I think those were kind of the big things for this.
Yeah, another thing too, so I've heard what this is. So this is TTN, but what it's been described as is this perihilar streaking. So you can sort of see the lung markings beginning perihilar and then going out to the periphery, but not reticulogranular like the RDS, which would cover sort of, especially like on the left lung, those areas that are very dark, like that would be covered in a reticulogranular pattern that would be more like snowed out all the way to the periphery. But this is more perihilar streaking, sort of shooting out, sort of like the sunburst pattern kind of from the middle. And that's more typical of TTN, which is what this is.
All right, let's see. Next one. So going along with that case, I think it was, you know, obviously these answers are going to be kind of changed based on what you thought it was, but which of the following is most likely to be associated with TTN? That's going to be that full-term baby, especially who had a C-section, and then maternal diabetes is associated. Again, my logic is kind of more like, well, maternal diabetes is more associated with C-section. So yeah. Those two together.
Yeah, so something to remember here, as far as the gestational age, it definitely can happen to premature babies. It's kind of an unfair question to ask because it does happen in prematurity, but when there is respiratory disease in full-term babies, it's most likely TTN. So kind of the backwards answer to this question, which I apologize, but definitely, so very, you know, deliveries basically in which you don't get that squeeze going through the vaginal canal, getting that amniotic fluid out. So that would be C-section or a precipitous delivery, which makes C-section correct and prolonged vaginal delivery incorrect, because that would be a lot more squeezing and getting that amniotic fluid out, which is the whole problem. And then again, meconium stained fluid is more post-term, and that would be the meconium aspiration syndrome, obviously, and that actually is not associated with TTN as much as it is MAS. So, and then maternal alcohol consumption doesn't have any relation. That was just kind of in there to throw you off.
Perfect. And I feel like, again, since infants of a diabetic mother are at increased risk, possibly putting that, you know, like a infant of a diabetic mother who's, you know, 32 weeks old or something like that may be reasonable. But I agree. I think that for TTN, we want to mostly do full term as like the most likely association. All right, case number 2. So this is a little 30-minute-old female whose respiratory rate is 80. This is what y'all had put. And for RDS, I feel like the whole reticular granular pattern, ground glass pattern is like the, hallmark sign that you gotta be able to associate with it. And so y'all putting that is perfect. And I think that y'all probably kind of by saying diffuse interstitial opacity and things like that, essentially we're describing it. But if you definitely want to be able to recognize those terms. If they were to be describing this image, you'd want to be able to associate the ground glass or reticular granular with RDS.
Yeah, and as you can see here, compared to the last one, so like I said, the TTN had the perihilar streaking with the markings not making it all the way to the peripheries. This is like the peripheries are totally whited out. You can see the reticular granular pattern all the way to like the very rib edges, suggestive of that. And then in this one, especially on the left lung, you have some really good air bronchograms you can see, which are very characteristic. So.
Perfect. And let's see. I just wanted to say thank you for the person who's, who like went to the trouble and who gave us, such a great answer of talking about the airway and talking about fracture and like doing all the things that we're supposed to do whenever we talk about radiology. That gives us more stuff to be able to teach and learn from, and just thank you. All right, and then y'all, for the most part, got the correct answer for that case of being RDS. There was a little bit confusion about TTN and then also possibly meconium aspiration syndrome. Again, as Scott said, the TTN, we're going to see it kind of more the perihilar area, and then meconium aspiration, we don't quite see it. It's not quite so coarse like the other image was. All right, case number 3, 36-hour-old with some bumps and no other symptoms. So I wanted to talk briefly about kind of a differential of vesicular lesions in crops. And these would definitely be called vesicles. They are basically raised lesions that are very small that have clear fluid in them. That would be in contrast to a papule, which would be a raised area that doesn't necessarily seem fluid filled, which would also be in contrast to a pustule, which would be a raised area that had more like white or pus-like fluid in it. All right, so if you look it up to date and look at the differential diagnosis of pustular and vesicular lesions, it is big. And a lot of these I have never heard of, like these things down here in the congenital disorders. However, if you just look for the things that have vesicles, and then you see that scabies is never present at birth, that eliminates a lot of things. So we'll talk about these things that are remaining real quick. What I did is I pulled in some pictures here. So HSV, which is what that image was, obviously we know that this is a big deal. We do not want to miss this, but likewise, we don't want to miss varicella zoster either. These would both be important things to consider. Again, with chickenpox or varicella, we definitely want to consider, kind of the age of the lesions, because typically they should kind of be different ages more. Candidiasis, which I had no idea could actually cause vesicles, kind of looks like this, which I think it's pretty clear how it's not quite the same as neonatal virus things, basically. It's not little crops, it's not single really, it's kind of a lot more diffuse. Kids with the congenital candidiasis can also have like thickened skin or like really dry, peeling skin, definitely take a look at it at some point if you're curious, or if you plan on doing a lot with babies. Finally, this is something I had never heard of, but it seems like it could actually be helpful to know in that it's very characteristic. So let's see. I don't know how to say this. Let's call it IP. IP. So it's going to have 4 stages. The first stage is actually a vesicular stage. And it goes down the lines of, oh goodness, what was that B word? We learned this in med school a long time ago. But the kind of lines that you would want to do incisions in that would be more cosmetically nice are the lines that this is going down. Please tell me if I'm making no sense.
Lines of Blaschko.
Yes, thank you, thank you. So it's going down those lines, and you can see that pretty clearly. It's not really just straight up like dermatomal, because obviously we've got some on that arm, and then we've got some on the other side on the belly. But it's going to be vesicles in those lines. And then there's other stages too that we're not going to go into today. But this is something that you definitely can see in newborns, and it would certainly kind of make you think about HSV or VZV, but it's completely different. All right, so this is what y'all had put for that one. I think that pretty much everybody put vesicles. We've got some people saying like pustule or bullous. For how zoomed in the image was, I could definitely see saying bullous if you were like, well, I don't know if that's, 5 centimeters or like 5 millimeters. And then pustular, again, it's hard to see for sure, but I feel like generally we feel like this is clear fluid there. But I understand it's hard to see for sure in like just pictures. And then I love that this person put all appearing in the same stage. That's perfect. I think that's really all I got on this. Good job. Then as far as how treatment goes, pretty much almost everybody got that right. The acyclovir, the amoxicillin. I'm not sure if that was maybe for like secondary infection of that kind of icky looking open bit. But definitely if you see vesicles like this, even if you're thinking about that IP thing, you definitely want to probably go for acyclovir and then kind of work up other diagnoses and take it off if you're confident that it's a different diagnosis. Obviously, if there is super infection, definitely treating with something that covers skin, but acyclovir would be the most appropriate treatment initially. All right, babies with owie eyes. These are both gross. I hate eye stuff. I don't know about y'all. So this first one was a 7-day-old. And really with these, it is all about the timeline. I mean, I'm sure that there's differences as far as crusting and unilateral versus bilateral and all that, but honestly, the simplest thing is just the age. So most of y'all got it right. This one was chlamydia for the 7-day-old. And then for our 3-day-old here, we're actually fairly split. We had 4 and 4 for chlamydia and gonorrhea. And so I think that's just, I mean, again, this young, you're definitely going to be kind of more in the gonorrhea stage, and we'll go over exact kind of cutoffs in just a moment. And then finally, for really like less than 24 hours, some sources even say less than 12 hours, having some sort of eye irritation is going to be chemical conjunctivitis, which most of y'all put. Some of y'all put like birth trauma or just like normal stuff. which honestly I think is fair from the description. We just kind of wanted to more go for the chemical conjunctivitis, really from like the erythromycin ointment that we'll put in eyes. And then I love, love, love this term. It is a made up term, but it sounded legitimate. I like Googled it just to make sure if it was a thing or not. Transient erythemata neonatal. So that was good. And then again, all about that timeline. So rule of fives for neonatal conjunctivitis is 0 to 5 days, is going to be gonorrhea. For 5 days to 5 weeks even is going to be chlamydia. And then this is kind of more for the older kids that we might see like in clinic or in the ED or something. The more common pathogens for conjunctivitis like this that are bacterial are going to be streptococcal or H. flu. This is a mnemonic I made up. If it works for you, awesome. If not, that's fine. So N gonorrhea happens now G, and then C trichomatis comes with time, just to kind of help remember which one's first. All right, treatment. So for gonorrhea, it's going to be ceftriaxone, 25 to 50 mg per kg in one dose, of max of 125. You got to watch for that hyperbilly in this age, of course. And then chlamydia, you're going to do erythromycin, 50 mg per kg per day divided in 4 doses times 14 days, or azithromycin, 20 mg per kg once daily for 3 days.
Yeah, and this actually came up with a patient a couple weeks ago who had was 5 days old and presented with conjunctivitis. So it could have been either. So we ended up swabbing, but while we were waiting for the swab to come back, we treated. And there was a question as to whether or not azithro or erythro would be the best. I think in that baby, we ended up doing azithro, but then in another one with potential chlamydia, we did erythro or something. So the actual recommendation first line is erythromycin because it's believed that it has better studies behind it. And I'm pretty sure, I think like Christina or someone had said something that's what ASP, specifically Dr. Birch recommends is erythromycin, just because it has more studies backing it up. So even though it seems like azithro would be a lot easier from a compliance standpoint, erythromycin is preferred. And then the ceftriaxone, that's what all of this comes straight from the Red Book. Ceftriaxone, the range is kind of broad for exactly what to dose. So I guess talk to ASP in that sense. And watch for hyperbilly. We did have a kid who was a little jaundiced. We ended up giving the ceftriaxone because he was such a hard IV stick to try to start something else IV. There are some alternatives, but it was just going to be so much easier to give him IM ceftriaxone, and that's what we ended up doing.
Thank you. All right. I think this was the last case. So just a runny nose or not? No. This is a baby with congenital syphilis. I think there was a few people who maybe had question fatigue or something, so I don't know that we got all the people who answered responding to this one, but of the people who responded, 4 people thought it was syphilis, and then 2 thought it was a metabolic disorder, which I love that y'all are thinking about kind of those more broad, difficult diagnoses. This baby has some nasal bridging, and that's due to the periostitis that you see with syphilis. So you can kind of see that the brow is really forward, and then the nose kind of really dips down, and then it kind of poops back out. There's also obviously the weeping nasal mucosal lesions of syphilis, and that's what's causing snuffles or that really, really runny nose look. There's also a perioral facial rash, which I honestly, the first time I looked at this picture, didn't even realize, but you can see kind of, I would say some areas of, like, it's almost like a serpiginous spread really, but some areas of pallor with like a slightly hyperpigmented like rim around it, I guess I would say. And then again, I think Dr. Cooper just did his torches lecture in the last month or so. And so the pathognomonic placental pathology is going to be necrotizing funicitis, which is this basically kind of that like barber pole appearance to the umbilical cord. And that's associated again with this syphilis. Most important part for last. All right, jokes time. I told the doctor I didn't want brain surgery, but he changed my mind. And then the beauty of Mount Rushmore prior to being carved was unprecedented. All right. That is all that we've got. I wanted to, again, thank y'all so much for participating. This would be nothing without y'all's responses for us to discuss and kind of continue to work with. Anybody have any questions or comments or anything?
I just wanted to make an announcement when you guys are all done.
And I didn't know if Dr. Gibson was on in Newborn and had any questions or, comments or anything.
All right, Gabrielle, what's up?
I just sent a Google spreadsheet to everybody. I think Whitney actually sent it out, but just click on that. It's basically for us to fill out for the new coming intern class, like where we live, any recommendations for housing and whatnot. I know it was helpful for my class to have that. It wasn't sent out last year, so I wanted to make sure it gets sent out this year. So it'll be like 2 minutes, and then I'm going to send it out to them on Monday. Thanks in advance.
Thank you. All right, well, thank you all again so much. The next Physical Findings Friday will be on April 9th. And it will be some like rheumatology stuff, and Dr. Dingle should be joining us for that. All right, bye.